started on this webinar here. It's basically kicking off our research lecture series for the SIR-RFS webinar. And we want to thank you all so much for taking your time to join us tonight here with Dr. Erinjeri. And thank you so much to Dr. Erinjeri as well for graciously agreeing to take out a chunk of his time tonight to portray this information to us. Some people are still trickling in, so we're going to get started, and I also think that some people can view this webinar without actually logging in, so I think there may be some viewers who aren't showing up here. So we're just going to go ahead and get started then. So we have with us here tonight, very thankfully, Dr. Joseph Erinjeri. He's an interventional radiologist at Memorial Sloan Kettering Cancer Center in New York City, and amongst his expertise, he does a lot of liver cancer, lung cancer, melanoma, soft tissue sarcoma, and things along those lines. And he's going to kick off our webinar series and research talking about how to get started. And I hope you all take away a lot from here tonight. And I think it would maybe behoove some of us to take some notes as well, just to keep these pointers in mind along the way. So without further ado, thanks a lot, Dr. Joseph Erinjeri. I'll let you get started on your lecture.
Thanks a lot, Rajat. Really appreciate you having me. It's kind of fun to do webinars. There's a couple of reasons why. You never see the people walking out of your lecture and going to do something better, so that's a nice reason to do the webinar right from your office. And the other thing is, you know, this is a good example of where when you're like talking to yourself, like in your office, like nobody thinks it's a bad thing. They actually think it's a good thing. So tonight we're gonna talk a little bit about getting started in IR research. And as I mentioned, I'm Joe Erinjeri from Sloan Kettering. So first, let's just talk a little bit about being a physician versus being a physician scientist or a physician researcher or an academic physician, whatever you want to call it. And you know, there's some distinctions, and I think it's good to think about this before you jump into research, because it has to do with, like, why do you want to do research? So when I think about physicians, there are people who want to help this patient. But when I think about researchers or physician scientists, I think they're thinking about how do we help this patient plus the next 1,000 patients. When we think about physicians, when are they helping the patients? They're helping them right now. And the physician scientist is trying to think, how do we help the patients in the future? When we think about where are they helping, the physicians are helping them in the IR suite or at the bedside. But the physician scientist is working on the computer, they're working at the bench, they're working in the animal lab, in addition to working in the IR suite and at the bedside. And how is the physician helping the patient? Well, they're performing a procedure for a specific disease, and the physician scientist, in addition, is trying to understand the procedure or disease. So it's an additional group of ideas. They're kind of a little lofty, but they're still kind of exciting, and that's one of the reasons I like doing academic medicine or being a IR physician scientist. And what I say is this, like, we need both. We need physicians and we need physician scientists. IR is a great specialty, but for it to continue to be a great specialty, we need great physician scientists. And look, I'd just like to say, you know, for those of you that studied medical history, you know, this was a big part of the Flexner report back in the early 1900s about how to improve medicine. And it said, let's make it rigorous. Let's bring science into the treatment of patients. It really influenced the development of research as a part of surgery in the 50s and 60s. And I think because as our specialty is a nascent and new specialty, this is a great time to be a physician scientist in IR. So this is a very common scenario. You're in the procedure room, you're doing a procedure on a patient, and one of the operators will say, I definitely think blank is best for this patient. And, you know, either the attending or somebody will walk by and they'll say, well, I definitely do not think blank is the best for this patient. And, you know, sometimes the conversations get a little heated, and these conversations even get heated at the IR meetings. But part of doing medical research involves being the bullshit police. And this is part of it. Like, there's a lot of bullshit that goes around. People just puff up their own ideas. But how do we know what really is a good idea? And peer-reviewed research is the bullshit police of medicine. And we need more people on the force. this is how we resolve the conflicts that occur in medicine. So what's a physician scientist day, or what's the process look like? So I'm just going to go through the big process. And the truth is that you really should think of it from the beginning to the end, and so I want you to get a sense of this. Doing part of this is not the best, so try to see if you can pull and look at this from like beginning to end. So you start with a clinical question. You form a hypothesis, which is basically putting your money on the table and taking a stand about what you think, at least mentally. You design an experiment. You apply for funding, because usually it's hard to do experiments for free. You perform the experiment. You analyze the data using statistics. You present the data at a meeting to get feedback. You write the paper up and publish it in a journal. And that's it. And hopefully you refine that process again and ask another clinical question. The most important step, as far as I'm concerned in this process, is forming a hypothesis. This idea of like, well, maybe I'll look into this and start to understand this. Maybe after I start looking at the data, I'll come up with an idea about what I actually think. You know, it's not the best way to do research. It's better to commit to an idea, have an idea, you know, form the hypothesis, say, I think this is what what ground truth is, and then try to either prove it or disprove it, and then refine that hypothesis as you go along. And you'll find that is a way that you kind of make a commitment to the project that you're doing. So I'm going to give you an example of a project that I worked on with a resident when he was a resident. Now he's an attending at Cornell. His name's Steve Lee. So we had this 64-year-old patient. He had kidney cancer and a biopsy-proven lung met. He was not a surgical candidate and was not a candidate for radiation therapy. So in this case, there was a clinical question. And the clinical question was that I asked, and I wasn't sure, was how should we approach this lesion for microwave ablation? Like, I just wanted to figure out how to do this case. And so we had a couple of choices. Choice number one is to come directly at the lesion, and choice number two is to come at this from the side. Now, if we're in a, I don't know if you can actually hear me, and I usually put this to the audience, and like Rajat or any of these other people who are on this webinar, do you have any ideas about how you might go across this? Go about, which one do you think looks better to you?
Going top, the vertical arrow?
Yeah, and why, just out of curiosity, why do you think that one's better?
Because it looks like the lesion's going up against the pleura, probably less likely to cause a pneumo. I don't know. Right.
So it's an interesting idea. Like, you know, I can see it both ways. Maybe it's based on the pleura. You can see the long axis is kind of arranged, you know, top to bottom, so you might get the lesion better if you come from the top, but you also might be hurting the pleura. If you come from the side, maybe you have less of a chance of hurting the pleura, but maybe you're not going to get the whole lesion. So contrast the clinical question with a research question. So we can boil down this research question into a more specific kind of question. So during microwave ablation of the lung, does the geometry of probe placement affect the risk of pneumothorax? All right, so we've now posed this as a research question, and we can move on. Now, a research question is a question, but what we need right now is a hypothesis. We've got to put our money down on the table. We've got to make a bet, and you're making a bet as to which one we think is best. And so here we've kind of drawn a schematic, and we're refining the research question, not based on this particular patient, but based on a general patient and a general approach. So here's my hypothesis, and this is the hypothesis we worked on for this particular project. For a fixed distance between the emitting zone of the microwave probe and the pleura, probes placed perpendicular to the pleura will result in a significantly higher rate of pneumothorax than those placed parallel to the pleura. So now we've made a general case, and I'm putting my money on the table. I'm saying I think this direct approach is going to be worse because it has a bigger chance of hurting the pleura than this approach will. All right. So we have the hypothesis. I'm going to either, you know, go down in a blaze of glory, or I'm going to, you know, be glorified here. So Steve Lee took this hypothesis and he wrote it up for a SIR pilot grant. And he called this grant optimization of probe geometry and ablation power to minimize pneumothorax following image-guided percutaneous microwave ablation of the lung. You can see this was based directly on a clinical question and turned directly into a grant. And I think the reason why he got this grant is he had a really good hypothesis. He had a very clear hypothesis. All right, so we talk about funding. Well, there's a lot of funding options. The RSNA is one of our parent foundations. They fund a lot of pilot grants. This is another agency that has given me money in the past, the Curing Kids Cancer Foundation. The Society of Interventional Radiology, of course, funds 10 or more pilot grants a year, as well as some bigger grants. There are other government agencies like the National Institutes of Health. Obviously, those are like the big time. Those are big time granting agencies. Lots of internal grants from hospitals or universities, and of course philanthropy. Surprisingly, there's a lot of philanthropic funding as well. Believe it or not, big in the news. Oliver Sacks actually gave me $10,000 for my research because he liked my research. So God rest his soul. He was a great guy. And industry. Industry is another great place to get money as well. And particularly if you're doing like device-related grants, we could have written actually, to believe it or not, New Wave Medical Systems actually gave Steve an additional $5,000 in the middle of this project to help complete the project because they liked it so much. All right, so here was the experiment. So in the experiment, this is how it worked. So we took a pig, and here was the clinical paradigm that we were thinking about. And what we did is we put a probe in, and we started to ablate the lung either perpendicular to the pleura or parallel to the pleura. And so I'm going to just show you the results here. Here's an example of doing a perpendicular ablation to the pleura in our swine model. Here's an ablation that we did parallel to the pleura. And we collected the gross pathology. I don't know if it's a little dark for you guys, but you can see here there's kind of a target lesion where we've burned a big hole in the pleura where the probe entered. And here, parallel to the pleura, we can see that the pleura got burnt, but there was no hole in it. So the next stage of this is to build a giant data analysis table. Now this is the table that Steve built, and I'm going to show you here he's gone through each of the different ablations in animal number 1, animal number 2, animal number 3, animal number 4. He looked at the exam numbers, exactly where the gantry was, what lobe was ablated, if it was in the parallel or perpendicular, and this is a really complex table. Now, before we get to this, I just want to talk a little bit about data tables because this is really the essence of doing research, and it's the most important part when you get started. It's really important to get your data table right before you start. So I'm going to go through just a little bit about data tables, and I think in this webinar series, you're going to probably hear a lot more about this, but I just want to get you started. So generally speaking, when you form these data tables, the rows of the data tables are going to be your patients or the tumors, and the columns are going to be the different variables that you are measuring. So just going back, here we see here are our subjects in each of the rows, and each of the columns is a different variable that we're measuring on the subject. It's important to note the variables that are dependent variables and the ones that are independent variables. And we're going to talk about what those mean in a second. So to make this a little simpler, I felt like, it's really hard to put a dry topic like pneumothorax and ablations and make this more relevant to what we're talking about. So I thought I would bring a more important topic that might be more exciting for groups of medical students or residents. So factors which predict dating successfulness of medical students. Okay, so let's say this was your research project. I'm sure we're sort of all in the past doing research on this topic. And here's a data table that I made up today. And notice I've used the same format. Each of the rows represents a subject, and each of the columns represents a variable that I'm measuring. So here you have different subjects here. These different male subjects have heights. They have a different sort of category of look. Some are average, some are not so great looking. Some of them are really smart, some of them are okay, some of them are really rich, some of them are poor. Some of them have awesome, sweet cars, like my dream car, a 911 GT Turbo. And then we have other variables, like what we're actually predict the successfulness of these medical students at dating, the number of dates per week that they're getting, and then this other binary variable telling us the successfulness of them obtaining long-term relationships. Now, when we look at these variables, some of these are what we call dependent variables. These are the variables that, not surprisingly, depend on the other variables. They're based on the other variables, whereas the independent variables are the ones that we measure, which we use to predict the dependent variables. It's really important because this is what's going to help you. When you're doing your studies, your study outcomes are going to be the dependent variables, and the factors that predict them are going to be the independent variables. Now, once you create like a good data table like this, the next step is to start asking some meaningful questions. And I'm going to just try to give you, this is sort of like biostatistics for dummies, and I consider myself an interventional radiologist, so we're like kind of like we're like the Neanderthals of medicine, so I'm going to keep it real simple for you and for myself. Here we see each of these different types of variables can be broken down into either continuous variables, which are usually the numeric variables that have sort of a variable amount of spacing, and then the categorical variables where they're sort of discrete and put into bundles or bins according to categories. So we take our data table, we've identified the independent variables and the dependent variables. We know which are categorical or which are continuous. Now we're in a position to actually ask some statistical questions. So here's a statistical question. Is there a significant relationship between height and dates per week? Now, how do we pick a statistical test for this? Well, first we identify what's the variables that we're trying to predict. Well, height is one of the independent variables, so that's going to be one of the variables that we're using to make the prediction. It's continuous. Dates per week over here is a continuous variable, so we're using a continuous variable to predict another continuous variable, and to do that we always use regression. So continuous variable predicting another continuous variable, regression. Is there a significant relationship between looks and long-term relationships? Okay, looks is a categorical variable, and we're using that independent variable to predict a categorical dependent variable, which is successfulness of long-term relationships. I don't know if anybody knows this one, but when you use a categorical variable to predict another categorical variable, the statistical test you use is the chi-square test. Well, there's some subtleties to that, but for the basics of this, a chi-square test. And finally, as just another example, is there a significant relationship between looks and number of dates per week? In this case, it's a categorical variable, independent variable using to predict a continuous dependent variable. In this case, if the category has only 2, we call it a t-test, or if there's 3 or more categories that are being used to predict the continuous variable, we use an ANOVA. So right now, you can see that based on your data table, you can really quickly pick the test that you're going to use. You may not know how to do regression. You may not know how to do a chi-square test, but you can quickly identify the kinds of tests that are going to be relevant to the questions that you want to ask. And then you can go to your statistician and say, look, I'm trying to figure out how to do regression on this. Or can you help me run a chi-square test on this particular subset of my data? Now I'm going to go one step further, and let's say, what if you want to look at all the factors that predict dates per week, all at the same time? In this case, we're using multiple independent variables to predict a particular continuous variable. And in this case, we use multiple regression, which is also known as the general linear model. And you'll see that come up time and time again. Or alternatively, what are the factors that predict successful long-term relationships? This is that yes-no categorical variable, so multiple factors predicting a categorical variable. When there are 2 categorical variables, like a yes-no, we call that logistic regression. And when there are multiple categorical variables, we call that multinomial logistic regression. These are the big 5. And just to repeat them, the big 5, I'll go back to the previous slide: regression, chi-square, t-test and ANOVA, multiple regression, and logistic regression. If you know these 5 tests, you know 95% 98% of all the statistics you're going to see in any paper that you ever do. You're also going to be able to take any square data set that you are able to make, which is how most people do every one of their datas. Just make a square data table. You can analyze it in any number of ways. And this is really the crux and the basis of doing statistical analysis of your data, one part of a big research project. All right, so let's go back to our data. So we have our microwave ablation of the porcine lung. We've got a categorical variable here on the one side, which is parallel and perpendicular. We've got a pneumothorax rate for both of these, 31% versus 14%, right? So it's a categorical variable versus a, in this case, yes-no pneumothorax, another categorical variable. We used a chi-square test, and we came up with p less than 0.11. In this case, our hypothesis was pneumothorax rate is significantly higher in the perpendicular approach versus the parallel approach. We're going to reject that hypothesis. It was not statistically significant. We therefore came up with a second hypothesis. That's great. That's what you do when your first hypothesis doesn't work. We thought maybe pneumothorax rate is not significantly different at low power, but may be different at higher power. And I can just tell you that we tested that hypothesis as well using our data table, and that hypothesis wasn't true. So we then went to do exactly what I just showed you. We did a multivariate analysis. We wanted to take all the variables and to see which of those variables predicted that yes-no pneumothorax rate, and we performed the logistic regression, multiple logistic regression, and you can see that of all these variables, temperature didn't predict it, probe angle didn't predict it, probe geometry didn't predict it, but what did predict it was the ablation zone, including the pleural puncture site, that had a very high odds ratio, and it was significant. We also predicted that the number of ablations in each lung was predictive, not as much as the ablation zone, including the pleural puncture site, and also the amount of time of intubation. Now, we had 3 variables of the 10 or so variables that we were measuring. Keep in mind, of course, that let's say we measured 20 variables, at least one of them would come out significant, right? 95% confidence level. So we performed the multivariate analysis to see which ones are independent of each other. And notice at this point, only ablation zone, including the pleural puncture site, was positive, as well as time since intubation. What happened to the number of ablations in each lung? Well, it's clear that the longer you're intubated, the more number of ablations that could be performed. So these two were not independent of each other, and that's why it fell out in the multivariate analysis. You can see the odds ratio actually went up during the multivariate analysis, telling us that ablation zone, including the pleural puncture site, was very significant. So let's keep going. So here, based on our results, we have our new conclusion of our paper, which says, geometries where the pleural puncture site excluded the ablation zone decreased pneumothorax in swine undergoing microwave ablation in the lung. And you can kind of now see from the growth pathology that this kind of made sense, right? In the case where you're poking directly in, you can see that there's this big cauterized gap in the pleura. But notice that when the pleural puncture site is far away from the ablation site, even though there's thermal injury to the lung, the pleura remains intact. And here's another example where it's just, here it's starting to get closer. The ablation zone is including the pleural puncture site, but it doesn't go straight through it. Notice we still have this burnt cauterized hole within the pleural puncture site. So it doesn't matter that you puncture directly through it, but it still included the puncture site, and that turned out to be the biggest factor. Now, Steve did a great job, and he wrote this up recently, and I think it just got published in JVIR about a month ago, and he was involved with this, and so this was a great start to his career. So what does a typical week look like for me? I do cases 2 days a week. I have a clinic 1 day a week where I see patients, and I can set patients to my studies as well as just planning for their procedures. I do meetings and conference calls about 1 day a week as well, and I meet with students. I got a meeting at 6 o'clock with a student, another student about a project, Metaport project. I meet with my postdocs. I meet with industry, or I have conference calls with them. And I have kind of a 1 day of research per week where I actually, sit down and crunch the data. Manuscripts, grants, preparing talks. And really what we're talking about is this cycle where you do cases, it gives you clinical ideas, and those clinical ideas become the foundation for research, and hopefully that research changes the way that we do our cases. Like in this case, like I try to avoid putting the probe in a way where the pleural puncture site's going to get burnt on the pleura, because that's not going to really be a good idea. And that keeps that cycle flowing. So in conclusion, I'd say do some research in IR, whether it be lab research, clinical research, economic research, operations research, which we do a lot of here at Sloan Kettering. And the most important part is to make a hypothesis. Try to avoid doing what we call descriptive research, where you're just like, I think I'll just, just kind of count up a bunch of something and see how many of these we've done and see what we see. It's great and all, but it doesn't really push the specialty forward very far. What pushes the specialty forward is making a hypothesis based on what you think and then testing it to see whether it's true or not. It's important to get a mentor. It's hard to do all this stuff on your own. I had great mentors all the way through my career. Some of the mentors that I worked with, Dan Pikus at Mallinckrodt, who's a former editor of JVIR. I worked with Tim Clark at NYU, and now Steve Solomon and Hedy Resac at Sloan Kettering. These guys have been great mentors to me, and that makes a big difference. Apply for a grant. There's nothing that helps you to really crystallize your ideas more than actually writing it down on paper, having your colleagues take a look at it, and then sending it out to get reviews. I probably wrote 8 grants before I got my first grant, and then I remember getting grants 9 and 10, and I was really, really happy about that. So it takes time. And definitely attend the SIR annual meeting. I mean, it's the clearinghouse for ideas and experiments and thoughts in our field, and it's a great place to really kickstart your research career. So I'll just finish by saying the next big thing in IR is it truly is just waiting to be discovered, and the best way to be part of it is to find it through research in IR. So I'll just stop there, and I'll take any questions.
Great. Dr. Erinjeri, thank you so much for all of that valuable information. I know there's definitely some things that you've mentioned there that I've relearned and now feel more comfortable with moving forward. So we'll open it up to questions right now. And again, if anybody has any questions, you can just go ahead and type it in the question box there, and it'll show up, and then we'll pass that right along to Dr. Erinjeri. And again, before we move along to the questions portions, this will be recorded and available on the YouTube channel. If you just go onto the YouTube channel and type in IR research, it will the whole series will pop up as we populate it with more movies. But Dr. Erinjeri, I guess the first question I have is, you talked about these 2 doctors in the OR there, and one says they do it one way and another says they do it another way, and kind of just looking at some of the articles that you read in JVIR and the one that you and or your colleague published there recently, it seems like a lot of these things, these questions that you come across are intuitive, or the answer that you're seeking are a little intuitive. But then that's in hindsight. After the article has been published, you've had a chance to read about it. I know I've definitely come across some scenarios where I just say to myself, well, why didn't I think of that? That seems so intuitive. I'll
give you an example. I was talking to Kareem Valji over in Seattle a few years ago, and we were talking about the question of whether we should give antibiotics before doing a gastrostomy tube placement. And I can tell you at my institution, there's a lot of debate about that. People say, well, does it matter? A dose of Ancef costs about $15. And so some people said, well, it's only $15. Why shouldn't we give it? And other people say it's unnecessary. It might cause antibiotic resistance. We definitely shouldn't give it. And Dr. Valji said to me, and I really respect him, he actually examined me for my CAQ. But when I saw him, he said, look, I'd rather do a randomized controlled trial and answer this question definitively than to keep talking to people back and forth about whether this is the right thing or not. And I'm sure that after the fact, anything seems obvious after you analyze that data table. But prospectively, you can look it up. You can look up and say, antibiotics for gastrostomy tube. If there are no papers on it, that's up for grabs, and there's no reason why you couldn't go and look at it either in a retrospective approach or using a prospective randomized trial.
Sure, yeah, so that makes a lot of sense. I guess my question would be, for people who haven't done as many procedures or at an early trainee stage, what would be your best advice to start, thinking critically in this sense and start thinking about how you're going to acquire these questions that you want the answer to along the way?
Well, I guess I would say question everything. That's it. I would say question everything. Probably, I don't know if I should take this as a compliment or as an insult, but one of my mentors from my fellowship, Dr. Karen Brown, a great interventional radiologist, wrote in one of my evaluations as a fellow, "It is exasperating how many questions Dr. Erinjeri asks during a case. However, it's heartening to know that at least he knows there are questions to be asked." And I think, I looked at that and I was like, is that an insult or is that a compliment? I'm not sure, but that's a great way to become an interventional radiologist, an academic interventional radiologist. You ask a question, and if somebody gives you an answer that doesn't quite make sense and you look it up, just put it on a little piece of paper and put it in your pocket and save it. I've got all kinds of little pieces of paper. I actually told my boss I wanted to paint one of my walls with that dry erase paint so that I could make one of those beautiful mind walls so that I could just write my ideas on these walls so I wouldn't forget them. But that's the way to do it. If you ask a question and it hasn't been written about, you see somebody do something and you just simply ask the question why, and you don't get an answer that really makes legitimate sense, or it makes great sense but it's never been written about, that is a great start to a project. Great.
I'll definitely keep that in mind along the way. I'm definitely going to start writing down all these questions I have in mind.
I'll give you another example. A patient asked me, this is sometimes somebody will ask you a question. A patient asked me, I had a desmoid tumor. I went to do an ablation on them, and they said, we were talking about immunotherapy, and they said, is it okay if I take anti-inflammatories like NSAIDs after my ablation? And first I just said, well, of course, it's going to help with the pain. And then I thought to myself, yeah, but, I wonder if that could have an effect on, the immune cells that are there. Hopefully those immune cells are going to be, finding dead tumors and maybe starting to have antigen presentation. So I don't know, maybe it's not such a great idea to take anti-inflammatories. And I thought more and more about it, and it actually became the start of, some of my research, including the stuff that I won the Ring Grant for. It was this question about whether, the kinds of immune cells that are present after ablation. And that was really the start of it. So asking questions is the way to go. It's not so much about finding answers. It's about just asking the questions, and what's going to happen is you're going to find questions that you personally think are worth asking. When you personally think of questions worth asking, that's the start of a research career. Something that interests you and intrigues you enough that you're willing to ask that question to yourself multiple times over days and weeks and sometimes years. I'm still answering these immune questions about how the immune system reacts to the body during image-guided ablation and embolization. So questions are really it.
Excellent. Awesome. Thanks so much for that. I guess while we wait for another couple more questions to roll in here, if anybody has any, again, you can type them into the chat or question box there, and it'll pop up, and we'll pass them right along. So I guess the last question that I personally have is, when you talk about applying for funding and writing grants, that seems to be, the cornerstone of a great IR project to receive funding if you can. And I know a mentor plays a lot into it, having a great person who's done this before to read through some of your proposals and things like that. I guess if you could just maybe give us maybe some of your most salient points or pointers for anybody who's thinking about writing a grant, and maybe if you could talk specifically about industry collaboration, because I know a lot of different manufacturers are very willing to, as you mentioned, provide some funding, especially if you're using their product.
Okay, so I'll first talk about writing grants. Look, writing grants sounds daunting, and you know what? It is kind of scary to like put your ideas down on paper and get, as I said like multiple times, put your money on the table and say what you think. And I think about it, oftentimes writing a grant is like writing a term paper in college. What that means is you're picking a subject and you're basically looking up everything that is known about a particular subject. Now, everybody knows that you have to finish your term paper, right? If you pick a subject like the Iliad, well, you know what? You can't write your term paper about everything that ever happened in the Iliad. It's too big of a topic. You're going to have to narrow it down. Likewise, you can't say, I think I just want to like write a paper. I'm going to do a research project on embolization. You got to boil it down to something where the number of papers or the amount that is known about a topic is like a finite amount, so that it's broken into an understandable part. And that's what a mentor is really, really good at helping people to do. You can know that, I'm really interested in blank. And then that person will say, well, let's look at a subset of that small idea and see if we can like think of something that applies to that. That's really one of the first things. And I do think finding a mentor is a really important topic. To find a mentor, you got to make sure that the mentor has got the time and got the ability to actually help you with that project. And sometimes that mentor is going to be close to where you work. It might be at your institution. It may not be at your institution. It may be somebody that's a little bit farther away. I've done a few projects with people that are, worked at different institutions, students even that worked at different institutions. But that works out best when you're doing like something that's more retrospective or something that they're able to work on independently. That tends to work better. The second thing about industry collaboration, a great way to get involved with industry projects is to attend the SIR meeting, to talk to the reps that are at the booths and ask them about some of the research funding that they have for different projects. There's lots of small projects that these groups are willing to fund. And also, like at some of the bigger institutions, particularly the ones that have labs, like Memorial Sloan Kettering or Penn or MD Anderson or UCSF, there are always going to be a lot of industry collaborations and a lot of different groups that are working. So this is these are good places to kind of get your feet wet.
Great, that's a great point. So definitely, if you're looking for industry collaboration, it would serve you well to attend these meetings and talk with a lot of the vendors there. It's a great point. I'm definitely going to try that. So we do have some questions that have rolled in here. First question is from Leanne Domini. Sorry if I pronounced that incorrectly, Leanne. Her question is, I'm currently an MD PhD student interested in doing genomics research or personalized medicine. Do you see any potential applications specifically in IR in the future?
Oh, great question. Thanks so much for that question. I feel like you're, I wish we had a bigger audience here. So, let's put it this way. I'm going to tell you this, and this is a little cliche, but when it comes to genomics research, the tissue is the issue. And nobody's got bigger access to tissue than interventional radiology. We're doing the biopsies on all the patients at our institution. Now, I'll just tell you, this is just what I did at our institution. First thing I did when I got here is I wrote a biospecimen protocol with our institution that basically said, hey, if we're doing an IR procedure on a patient, like a biopsy, and it's safe and feasible, I'd like to collect a piece of that tissue for my research. And, amazingly, they accepted this protocol. So, we actually have a tissue bank of patients who undergo ablation, and we do this. Now, I collected that for cytokine research. We also collected bloods for that as well. But now that same tissue is also now being used for genomics research. And our ability So as interventionalists, we have really unprecedented access to tissues. And we know how to obtain them in ways that that are, really, really amazing. Like, right, we can do it without doing surgery, without doing this big operation on a patient. So I think there's a huge potential for correlative studies looking at IR procedures where, the genomics of IR procedure. One of our faculty who just hired Dr. Itai Ziv, that's his whole thing. And he actually just won an SIR pilot grant, one of his mentors on it, where we're looking at the genetic profile of tumors as a marker for susceptibility for different types of local regional therapy. So 100%, Leanne, this is a big, big topic. Interventional, if we choose to get involved with it, we're going to be doing a great thing. Think about this. Why would we do all the work to do these biopsies and then just pass the tissue on to other medical oncologists or surgical oncologists for them to do the exact same research that we could be doing ourselves? So the tissue is the issue, and we've got access to the tissue. So that's IR is in a great position.
Great. Thanks a lot for that question, Leanne. That was an awesome question. Our next question comes here from Dave Tabriz. His question is, can you comment on any research involving IDEs? And for those who don't know what IDEs are, they're investigational device exemptions. In specific, if you wanted to study an alternative indication for an already FDA-approved device, would you pursue an IDE or consider conducting a small cohort of off-label use first and retrospectively evaluating?
So questions of like IDEs, which are those investigational device exemptions, or INDs, which are investigational new drugs. These are FDA issues, and they're really complicated. But when you think about it, it breaks down like this. If you're going to do, if you're going to take an existing device and use it for an indication that is not FDA approved, like think about it. You could hurt somebody, and you're conducting research on something, and you could potentially hurt somebody. So the FDA says, hold on, hold your horses, sucker. We'd like to know about this, and we'd like to comment on whether we actually think this is safe. Another great example of this is the investigational new drug. Like, let's say you decide that you want to combine a new particle. You have a particle that absorbs a certain kind of chemotherapy, and you want to add a new drug to it and see what happens. Well, it might be a great idea, but the drug may be FDA approved, the particle may not be FDA approved, but the drug plus the particle, when put together, is now essentially a new drug, and the FDA is going to want to comment on that, whether it's safe. So whenever there's any questions about sort of off-label use or needing to get an IDE or an IND, you definitely want to talk to your technology transfer office, and they're usually the people that are involved with that. Off-label use is different, right? When you're doing off-label studies, these are sometimes something is already FDA approved, but it's not considered, like, you're not using it in a way that is so out of the ballpark that it would be potentially dangerous. And we're not so much in IR. We've never been so much into therapeutic trials, so off-label use of drugs, it's not so big for us. But you do have to be a little bit more careful now. It's one of the interesting things, I think, about IR. We've always been a culture of innovation, and certainly I've done this. I've taken devices, or I've taken in individual patients, and for clinical care, I've broken the device in order to get a piece of that device or use the device in a way that is going to help that patient. Well, that's great, but when we're now using it to do research, you've got to be a little bit more rigorous, and you have to do things that are going to protect the patient. If you think about it, the FDA is like the IRB for the entire practice of medicine in the United States. they're like an additional level of safety to make sure that we're not going to end up doing something that hurts patients.
Excellent. Thank you for that very informative answer. So I feel like we have come to a point in time where no more questions are rolling in. I'm
going to just say one more thing, like with regard to data. Look, the best way to really get involved in research, before you even like conceive of a project, I think it's really cool to like not be afraid to just collect some data just to collect it, right? I mean, the idea that you start to like systematically look at something, and to start thinking along the lines of how do I take a question, build a data table, and then start to answer this question. I think a lot of people are really intimidated by the idea of picking different tests to actually do a statistical test. I actually, believe it or not, I never took a statistics class in college, or I took the normal statistics in medical school. I wouldn't consider myself a statistics expert, but I do, through the PhD training, I do feel like I'm pretty good at asking questions and knowing how to take the question and breaking down the question into something simple like, I'm using X to predict Y. How do I set up a data table to do that? And this, to me, is really one of the most important parts of research. I think there are more good ideas out there for medical students than I see from attendings. But what I see a little bit lacking is the ability to like systematically like set the data up in a way that's going to be really successful. I don't expect any medical student or any resident or fellow to be able to actually perform all these statistical tests. But I think like you guys are great at coming up with ideas, and to give yourself an opportunity to kind of think, how am I going to build a data table that could actually make some valuable predictions, and then take the beginnings of that data table or even the template for that data table to your mentor or your proposed mentor, because I think that's really like impressive when people do that. And I think it really shows the initiative, and it shows that you can actually get this project done. Sometimes actually when you apply for grants, you send them little tables about what you think the data you're going to collect is going to look like and how you're going to analyze it. I know Steve did that for his grants, and I think that was really helpful in him getting the grant. So just remember, the data is the most powerful part, so understanding how the data translates into ideas and into questions, which ultimately turns into answers and turns into papers and grants, that's the way to really start. And if any of you guys have questions, you can always call me. You can have a little curbside consult. I'll do the best I can to help you guys.
Excellent. Thank you so much, Dr. Erinjeri. We actually do have one more question that rolled in, if you don't mind. This question comes from Jahan Shah. His question is, how would you recommend approaching a topic of cost-effective therapy when comparing IR procedures to surgical procedures? How do you form those relationships that might impact the finances? Okay,
interesting question. I like it because we've got off the topic of clinical research, which is often like collecting like retrospective data, or laboratory research, which like is really hard and takes a lot of time, and it's really hard to build that stuff up, to some of the things that we talked about, which would be like cost effectiveness or operations research. So a couple of interesting things. Number one, huge topic right now, this idea of cost effectiveness. You'll see if you go online and check out the PCORI grants, there's a huge amount of money out there right now talking about the cost effectiveness of different kinds of procedures. A lot of interest in this field. So the first thing that I would say is, number one, there's a ton of available databases out there, particularly Medicare databases, which you can actually download, for free, and pull this data regarding CPT codes and the actual cost, people, different zip codes. It's already all anonymized, and it's a great place sometimes to pull a big data set and just play around with it. Now, you've got to be facile with like a statistics package like SAS or SPSS to actually manage such a big database. The second area where you can get that data is often talking to one of your IR attendings, because a lot of your institutions will have an institutional database. At our database at Sloan Kettering, they call it, it's no surprise, it's called IDB, Institutional Database, and it has all the procedures and that were ever performed, and it has all the cost information, and it has all the CPT codes, it has all the billing codes that were associated with it. And these can actually be, accessed, right? They're freely available. You just have to get an IRB to actually download the data, and a lot of times they'll give it to you. A great way to get involved with that is to get involved with the quality, I forgot the exact name of the part of the SIR, but there's like a informatics and quality section of the SIR. Dr. Jeremy Dirac is one of the Board of Trustee members, and he heads that section. So there's a whole section of the SIR devoted to this, and it's a great place to get involved. You're also going to see in the next few years large IR registries that are coming out, which are going to have like freely accessible data on procedures. So you may have an idea about, I think the starting pilots are with Metaports, IVC filters, uterine artery embolization. There's a couple other ones that I don't remember, but these are all coming down the pipeline. So people who are interested in these types of operations or cost-effectiveness research are going to have a plethora of resources to work on those things. So the person who can help you with that is Dr. Jeremy Dirac in the informatics and quality section of the SIR. He's a great guy. He actually works at Sloan Kettering.
Great. Thanks a lot, Dr. Erinjeri. I think you alluded to another talk we might have in this research lecture series down the line, which will hopefully address some of these IR registries. But along the lines of data and data collection, this next question comes from Janice Newsome, talking specifically about the data that is collected. How do you own your data, especially if you transfer to another institution?
Oh, okay. Real easy question. So obviously, anything you do for clinical practice, it's clinical, right? So if you're taking care of a patient, you're allowed to look up their data. No big deal. Once you start pulling the data to make systematic conclusions about that data, it becomes research. And research, we need to protect patients. So there are two ways that you make research, protected. The first way is you got to apply for an IRB. When you apply for that IRB, the IRB will either give you an IRB approval or they'll give you a waiver because it's like, say, retrospective or it's minimal risk. Sometimes you can do the data with the data anonymized, and when the data is already anonymized and you receive the data in an anonymized format, for example, like the anonymized data that you might get from a Social Security database or from one of the Medicare databases, since it's anonymized, it's already exempt, so you don't have to worry about it. What if you begin a project and you don't finish it and now you move to another institution? Like, can you just take that data with you? Well, no, you can't. And it's real simple. There's something that's called a BAA, a Business Associates Agreement. So you sign a Business Associates Agreement with, it sounds really fancy, but it's not. It's just a piece of paper that says, so-and-so is now a business associate of this institution, and being a business associate, now you're able to transfer data between you and the institution freely, and you can continue the work that you do. And sometimes if we decide to, certain companies will allow you to become a business associate, so if they're collecting data, you can work with the company, and that company will have to have a business associates agreement with your institution. But that's all there is to it. You sign a BAA, a business associates agreement, you become a business associate with that institution, and then you can transfer the data and continue working on it.
Excellent.
It happens all the time because, fellows leave, and it's like, well, how are you going to continue working on that data?
Mm-hmm. Great. Well, I think that brings us to the end of the 1 hour mark, and we're not going to hold you here any longer than we already have, but we do want to thank you so much for your time, Dr. Erinjeri. It's been a very informative talk, and I think all the attendees have a better idea of how to move forward once they start thinking about IR research.
Well, it's a start of a great lecture series, and hopefully some of these topics are going to come up again and again, and I think it's going to be great. Let me know how I can help.
Absolutely. We hope to reach out to you again some point in the future. And to everybody who has attended tonight, again, this will be available through the YouTube channel. If you just type in IR Residents or IR Research, it'll pop up there as a channel, and you'll be able to see all of these research lecture series webinars. And thanks again, Dr. Erinjeri. Hope you have a great night. And thanks again to everyone who showed up.
Thanks, Dr. Erinjeri.